Hello, everyone. Welcome to this webinar on dementia, memory and brain health research. I'm Marianne Talbot. I became involved in dementia research after seeing the impact it had on both my parents. My mum had Alzheimer's and my dad had vascular dementia. Their experience with dementia and my experience for caring for them led to my writing a book called Keeping Mum, Caring for Someone with Dementia. I'm proud to be involved with the work of Alzheimer's Research UK, who are supporting tonight's event. And a big thank you for the excellent questions you've sent in. We've had more than 50 questions submitted. I'm afraid we won't be able to answer all of them tonight, but we're going to do our very best. If you want to ask another question, please post it in the question and answer box, which is the little speech bubble at the bottom right of your screen. We'll do the best to answer questions there as well. Okay, if you'd like to change how the speakers appear on your screen, click the three buttons at the bottom of the screen next to the red phone icon. Then click Change Layout, then select either sidebar or spotlight setting. That's sidebar or spotlight. Also, if there's anyone who's hard of hearing, the captions can be turned on using the CC box at the bottom of your screen. Unfortunately, as you can imagine, we won't be able to answer questions about any individual case. The best thing, if you have concerns about an individual, is to talk to a healthcare professional. Tonight is about the medical aspects of dementia research, and this is the topic that we'll concentrate on. Tonight is being recorded and you'll be sent a copy of the recording, so don't worry if you miss anything. You'll be able to check it out later on. The event has been organised by the NIHR, or National Institute for Health and Care Research. This is a government-funded body that funds research into the NHS, public health and social care. The event is also, as I said earlier, being supported by Alzheimer's Research UK. They're the UK's leading dementia research charity, and AR UK is dedicated to research into the causes, diagnosis, prevention, treatment and cure of dementia. If you're interested in learning more about research and perhaps even in searching for studies you can take part in, you can visit the Be Part of Research website. The best way to find that is just to Google it, Be Part of Research. I'll mention it again at the end of the webinar. Please note that you don't have to have a condition yourself to take part in research on that condition. So tonight I'm going to be putting your questions to Dr. Vanessa Raymont. Vanessa is senior clinical researcher at the University of Oxford, and she's Research and Development Director at Oxford Health NHS Foundation Trust. Vanessa, please could you introduce yourself?
Yep, thank you, Marianne. As you've said, I've been a researcher in dementia for almost 30 years, actually, and worked in memory clinics for that long as well. I've worked in a variety of places in the UK. I currently work in Oxford, as you said. Have been there for the last 6 years, and yeah, very keen to take people's questions from here. So good to be here. Thank you.
Okay, well, let's get started then. The first question I've got is there any research into drugs to treat middle to later stage dementia? Presumably, we know we've got Aricept to treat early stage dementia, but this is to treat middle to later stage.
Yeah, I think this is a really good question, because I think a lot of people on this call will probably be aware that there's been a lot in the news over the last year or so, really, about new treatments that actually can modify the disease of modify Alzheimer's disease that is the commonest cause of dementia. But there's been less focus. A lot of these drugs are most beneficial early in the pathway of the disease, but there's been less focus on treatments for moderate and more severe dementia. So when it's in its later stages, what's really good about what's going on in research at the moment is that there's a much wider breadth of drugs being investigated at the moment. So this includes what we would call these disease-modifying drugs. So this includes lecanemab, which was the drug that was around in the news just before Christmas for Alzheimer's disease. As I said, probably works most effectively in the early stages. But there's also a lot of research looking at what we would call symptomatic treatments. So actually, the drugs we have, like Aricept, are technically symptomatic treatments. So they don't alter the course of the disease, but they help with the symptoms. And there's a lot more in that area. There's also a lot of trials going on at the moment looking at repurposing other drugs and whether those may help people with more moderate or severe dementia. These include things like antidepressants. So there's an antidepressant called mirtazapine, an antidepressant called escitalopram that are currently in later stage clinical trials looking at whether these may help with symptoms like agitation and restlessness. There's also a trial going on at the moment called the Aspect trial, which is looking at a particular ingredient that's found in cough syrup and whether that's something that may help again with agitation and restlessness. So we're seeing a real breadth in terms of the types of drugs that are being researched. Because these new disease-modifying drugs are such an exciting breakthrough, and I can't emphasize that enough, because these are the first drugs that are really proving real benefit for changing the course of things like Alzheimer's disease. They have been tested in people with more moderate disease, and at this point, there was a study done with a particular drug called aselanazumab, and that didn't show a benefit. But as we're starting to understand how these drugs actually work, there will be no doubt further trials, and it may be, as I said, that probably we'd be looking at combinations of things like symptomatic drugs and drugs that modify the course of the disease of things like Alzheimer's, that may be better for people with more moderate disease.
Okay, it's very comforting to hear that there's so much going on, and it's also exciting to hear that there've been breakthroughs. I mean, that really is good news, isn't it?
Absolutely.
Okay. Now the next question, slightly different sort of question. What is the latest research on brain health and exercise, and especially, asks the questioner, contact with nature?
Yeah, again, a really interesting area. We've known for quite a long time that anything that improves your cardiovascular health will reduce your risk of any forms of dementia or memory disorder progressing. But there have been some studies recently looking at whether type of exercise is important and also what environment you're in when you do that exercise. So there's been some research recently that has indeed suggested that if you exercise in the outdoors, that seems to have an effect on your cognition, similar to very acute exercise, so kind of intensive exercise over a short period of time. And what this seems to do is to increase blood flow to certain areas of the brain, particularly. So the front part of the brain that tends to deal with planning and decision making and switching between items, and also the memory areas of the brain. It's not quite clear why that happens. So there was a study quite recently that actually, it was a study done in Canada that was just published this year, which looked at electrical signals in the brain with something called EEG, and found that there was a particular change, again, that reflected blood flow in these particular areas of the brain. So we're certainly seeing something about exercising in the outdoors. And there's a sense that maybe there's some interplay between the psychological and the actual changes in blood flow in the brain. So something about well-being, being in the outdoors, particularly affecting blood flow in certain areas of the brain. But that's, that it's really not clear why it seems to be better to exercise outdoors, but there certainly seems to be some evidence that could be the case. Again, a lot of these studies are very small in terms of the number of people that are involved in them. So it's the kind of research that needs to be done at a greater scale to really see if this is something that holds true for larger numbers of people. And as I said, probably more importantly, why? Because some of the issues with these types of research studies is there's just too many things that can vary between people's situations of where they're exercising and so on, to be sure what is it that makes it better to be outside. But it's certainly an interesting area and something that's being researched quite a lot at the moment.
Okay, so as somebody who's a very keen gardener, I'm onto a winning streak, am I?
Absolutely, it seems that so. It seems so.
Okay. Well, the next question, it's actually a question, we've had quite a few like this. And it's very relevant to me, of course, having just introduced myself. Does having a parent with dementia or a wider family history of dementia increase your chances of developing the condition?
Yes, again, really good question. The simple answer to that is it depends on the type of dementia. So if I come to Alzheimer's dementia, which is the commonest form of dementia, in terms of the genetic risk, we broadly know that this depends on at what age you develop the dementia. So roughly speaking, we draw a line between what we would call late onset Alzheimer's dementia, which starts over the age of 65, and early onset Alzheimer's dementia, which starts before 65. For most people who develop Alzheimer's dementia, they develop it in later life, so over the age of 65. And although that seems to be associated with a particular gene that's called ApoE, and different percentages of the population will have different levels of this gene. So the one that seems to be particularly associated with Alzheimer's is called ApoE4. It's a particular form of this gene, and that exists in about 15–25% of the general population. If you have that gene, you are more likely to be at risk of developing late onset Alzheimer's. But not everybody who has that gene will develop it. So if you have one copy of the gene, your risk seems to go up about 3 or 4%. If you have 2 copies of the gene, it goes up maybe 8, 10, 12 higher risk. And it could be that in having the copies of those genes are somewhat genetic. But broadly speaking, if all you're looking at is that you have a parent, for instance, who developed Alzheimer's dementia over the age of 65, but you do not have the ApoE gene, actually you are at no higher level of risk, generally speaking, of developing Alzheimer's dementia yourself. Coming back to the early onset dementia, that's very different. So we know some very clear genes that are linked with early onset Alzheimer's dementia. And for most people, that leads to a much increased genetic risk. So if they have a family member, they're usually looking at a 50% chance of developing Alzheimer's dementia themselves. So it very much depends whether your family history is of somebody who's developed Alzheimer's dementia later in life or earlier on. And also whether the reason that you've got that family member that developed Alzheimer's is because you have this ApoE gene as well. So it's quite complicated. If you then come to the other forms of dementia, like vascular dementia, that's much less clear. Probably you're at higher risk if you inherit some of the signs that you have problems with vascular illness in your body and your brain, so signs of stroke, etc. Things like frontotemporal dementia, there seems to be a genetic link, but it's much less clear what the level of risk is in terms of inheriting the likelihood of you developing dementia if you have a family history of things like vascular dementia or frontotemporal dementia.
So I'm right in thinking that my father, who had vascular dementia, that's more likely to be his smoking, perhaps, rather than a genetic.
Absolutely. I mean, we know that some of the risk factors for developing vascular illness are genetic. But as you said, it's one of those types of disorders that we would call multifactorial. So what that means is there's a whole load of other factors that come into play in terms of whether you actually develop that illness or not. So in fact, the risk you inherit is very small. And what matters more is exactly that, all those other lifestyle choices like diet, smoking, levels of exercise, and so on, that probably have the biggest effect.
Okay, well, that takes me nicely on to the next question, which is what is the latest research showing the role of diet in helping to prevent dementia? And also, is there a link between Alzheimer's disease and the gut microbiome?
Yeah, again, I think an area that lots of people are very interested in, because we do know that, as I said, these factors in lifestyle can really impact on your risk of developing dementia. But again, very difficult to research, because you have to try and again allow for all of these other variables in people's lifestyle. So there have been some studies that have shown, if you look at mice, for instance, and you change the microbiomes in their body, that can promote the formation of amyloid bundles, and amyloid is one of the proteins that builds up in Alzheimer's dementia. And when we've looked at people with Alzheimer's disease, there's certainly some evidence that they may have a reduced diversity, a reduced variation of microbes in their gut, and they may actually have more microbiomes that are more likely to be what we call pro-inflammatory, so more likely to lead to general inflammation, and fewer anti-inflammatory microbiomes and bacteria in their gut. So there certainly seems to be something going on here, and there's the sense is that if you have more of these pro-inflammatory bacteria and less of the anti-inflammatory bacteria in your gut, that may lead to greater levels of inflammation throughout your body. And that seems to be associated with the increased buildup of this protein amyloid that's really important in the development of Alzheimer's disease. In terms of what you do about that, that's still quite unclear. And from a dietary point of view, we know that at the moment, the general recommendation is still about a good balanced diet, low in red meat, low in sugar, low in processed foods. Probably a Mediterranean type diet is what we would recommend the most. There is some evidence that certain foods that we know are good at reducing inflammation in the body. So things like blueberries actually may be beneficial, but we're still really missing the link between seeing these changes in gut microbiomes in studies and how you change them in practice and diet. And so again, it's a big area of research, and I do think in the future, and I kind of talked a little bit about this from the first question. Ultimately, I think when we look at treatments of dementia over the next few years, treatments for dementia or even to prevent dementia, they will be focusing on different aspects. So some of it may be about taking a drug to change the course of the disease, but some of it will be about managing some of these other issues that go on in the body, like inflammation. So it may be in the future you will be recommended a particular diet, but we're not quite there yet.
So should I rush out and buy some blueberries or not?
I mean, I think it doesn't obviously do any harm. And certainly there's some evidence that some of those anti-inflammatory foods may help, but it's certainly not the cure-all, I'm afraid, at this point.
Okay. Now, the next question is, what are the beneficial activities for people with mid-stage dementia? So this is people who've already got dementia. What activities are beneficial for people at the mid-stage?
Yes, interestingly, because we sometimes have such difficulty with identifying drugs that can help people in this area, again, there's an increased interest in looking at other interventions that could be helpful. So there's certainly some evidence from research that what we call reminiscence therapy, so encouraging people to relive memories and experiences from the past, seems to improve their quality of life and also potentially improve their day-to-day functioning. There's also some evidence that aerobic exercise may be very useful, and things like aromatherapy. So there was a review quite recently that looked at some of these non-drug treatments for people with moderate dementia and found benefit of all of those things. I think very pragmatically, the other thing that we look at clinically is always thinking, how do we support any other things that may be making somebody's dementia worse? So are they comfortable? Are they in any level of discomfort? Are they being stimulated? Are they enjoying day-to-day activities? And so on. So I think it's also about just trying to support somebody's other issues that may be going on in their day-to-day life, and trying to keep them engaged. I mean, we know that we're able to boost something that we call cognitive reserve. So this is your ability of your brain to deal with changes that are associated with dementia or any type of brain injury. That can continue to be boosted throughout the lifespan, whether you have dementia or not. And a lot of that is about stimulation, mental stimulation, trying to keep someone as mentally active as possible, encouraging them to get involved in activities, even if they find it difficult, trying to keep a breadth of mental activity going, and also a level of physical activity. And again, that comes back a little bit to the comment I made before about the benefit of exercise, and maybe particularly exercise in the outdoors.
Okay. And I've got somebody here who's, well, hardly a complaint. I was going to say he's complaining about so much dementia research seems to be about Alzheimer's. He says he's got 100% incident of vascular dementia on his mother's side, or her mother's side. Actually, I have no idea whether this is a male or a woman. What research is being done on this vascular dementia, and of course on the other many forms of dementia?
Yes, I mean, vascular dementia, you're right, is the second commonest type of dementia, and yet at the moment it feels like a lot of focus is on Alzheimer's dementia. I mean, I think honestly a lot of the shift is the fact that we are in a very exciting phase for Alzheimer's dementia, with these potential drugs really coming to light that can change the course of the disease. But in terms of vascular dementia, research at the moment is very much focusing on using existing drugs and how those may help vascular dementia particularly. So there's a study going on at the moment, which is funded by the British Heart Foundation, which is actually looking at a drug called amlodipine, which is a drug some people on the call may well know. It's used for high blood pressure. And it's actually never been tested in whether this would actually help with vascular dementia. So studies have been done in mice and found a benefit. There seems to be an increased blood flow in areas of the brain if you look at mice who have vascular dementia. And there's a hope that this will be extended to human trials very soon. So I think most of the research is focusing on how can we repurpose drugs in this area, given that we know vascular dementia is so connected to other risk factors like high blood pressure, diabetes, and so on. So there is research going on. Most of it is on looking at existing drugs, and there are some promising signs.
Okay, thank you for that. Now, we've got someone else with a family history of dementia, this time Alzheimer's itself. And this person says that they find that they're constantly forgetting things, and wants to know, when does this become worrying that it may be dementia? I'm sure that's a question that many people attending the webinar would like to ask.
Yes, absolutely. And I think we all experience that. I mean, we all experience times when we forget items, we put something down, we don't remember where it is, or we forget something that somebody's just told us if we don't write it down or make a note of it. Broadly speaking, the time at which you would start to feel more concerned about this is when it really starts to affect your day-to-day life significantly. So as I said, all of us have that, going into a room sensation and can't remember why we're there. That in itself wouldn't be significant. But if it was getting to the point where every time you went into a room, you were forgetting why you were there, so that actually that then delays you getting out of the house, for instance, getting to appointments on time, struggling to keep track of items that you need, like keys or things you've got to do, as you've got to use, like diaries or medication you may need to take, that would be more significant. So the broad benchmark is, are any of these issues starting to affect my day-to-day life significantly? And at that point, that's the time that when you would want to go and see your GP and consider whether you may need some further assessments. Now, where you draw that line can be quite difficult, of course. But broadly speaking, I would say if you are concerned, I'd encourage you to go and see your GP and have an assessment sooner than later, because it's much better to be told, well, actually, this is normal, this is part of normal aging, Whereas if there does seem to be some more significant problem, you can hopefully go on and get some treatment or support with that. But it's really about the impact it's having. Is it starting to significantly affect your ability to do normal day-to-day things like go to appointments, take any medication you may need, and so on?
Okay, and tell me, when you go to the doctor, if you go to the doctor about something like this, do they still do the what used to be called the mini mental state exam?
They do. There's another variation called the mocha, which is used a lot, and there's other kind of variations that GPs will often give. But those tests continue to be a really good screen, actually, for whether people seem to be suffering from a significant level of cognitive impairment. But again, it doesn't give you the whole answer. A lot of this is actually just about a judgment on the part of the doctor as to how significantly this is affecting your day-to-day life, because people score on those tests can vary hugely. So they're a good indicator, but they're certainly not the only way of assessing whether those kind of problems are significant or not.
Still, as you say, if you actually pass one in the doctors, you might feel slightly better about yourself.
Absolutely. And there's certainly a really good indicator, as I said, that they're used as a very effective screen for whether people are then, say, referred on to further assessments in memory clinics very, very effectively.
Okie doke. Now on to the next question. This person says, I lost my father to early onset dementia. Are there any developments with regard to treatments for early onset dementia?
Yes, I mean, as I think I may have said earlier, so early onset dementia is one of the subtypes of usually of Alzheimer's dementia is the one that's most referred to, and the early onset cases represent about 5% of all cases of Alzheimer's dementia, so it's a fairly small group. As I said earlier, we know they're much more genetic, so there are specific groups of genes that are associated with early onset Alzheimer's dementia. And unfortunately, people who have early onset Alzheimer's dementia, the course of the disease tends to be much more aggressive. So they tend to decline much faster in terms of their memory. Having said that, lots of people with early onset dementia tend to not have memory problems as the most significant issue, and a lot of people will notice difficulties with other areas of cognition, or particularly behavioral issues like agitation. The reason this is important is because we know that people with early onset Alzheimer's dementia, the changes in the brain seem slightly different than people who have later onset Alzheimer's dementia. So people with later onset Alzheimer's dementia, the primary area that gets affected are the memory areas of the brain, and these are called hippocampi. They sit in the just above the ears on both sides of our head. In early onset dementia, they don't seem to be quite as affected, and a lot of the disease appears to be affecting the kind of back of the brain. And so this probably explains why the presentations are slightly different. There's a lot of research going on at the moment as to whether these new drugs that we know are disease modifying will actually help people with early onset dementia. And there's evidence that's kind of not clear at this point. So some of the new drugs related to lecanemab, which was the drug that was just licensed in the US around Christmas time, that was trialed in people with early onset Alzheimer's dementia, and it didn't seem to slow down cognitive decline. But one of those similar drugs has shown some reduction in tau and amyloid in the brain with people with early onset Alzheimer's dementia. So it's not quite clear. I think people are very hopeful that those drugs may show a benefit for people without early onset disease, but it's not really clear at this point what those results will show from those studies. There are some pieces of research that are looking at broader treatments, so things like how much speech therapy helps people who have language difficulties, occupational therapy if people have particular issues with manipulating objects, which can, again, these are kind of some of the symptoms people with early onset dementia may have that people with late onset dementia may not be as troubled by. So there's the other kind of non-drug research that's going on as well, but in terms of drug research, a lot of focus is on these new disease-modifying drugs, but the results are not terribly clear at this point.
So we should just keep our fingers crossed on that one.
Yeah, and wait for further results. I mean, for people who aren't aware, this drug called lecanemab, as I said, that has had an initial early license in the US and is now being considered in the UK and Europe. The reason that the research was important recently was that for people with later onset Alzheimer's dementia, there seemed to be quite a significant change, not only in pathology in the brain. So I talked about this protein amyloid that builds up, but that equated to also changes in memory over time, over 18 months. And that was a really exciting thing that we haven't seen in research to date. I think what we will have to do is to wait for the outcome of some of these studies in earlier onset dementia to see whether we see a similar effect with that particular drug or others over time.
Mm-hmm. Interesting. And actually, my next question is about various drugs. Somebody's asking, can you discuss the efficacy of donepezil, Redimind, and Suvanade? And they also ask, what type of drugs are these?
So yeah, so donepezil is a drug that's been on the market since I think in 1994 was when it came on the market in the UK. And it's one of the drugs that we would call a symptomatic treatment for Alzheimer's dementia. So in theory, it appears to benefit particularly symptoms of Alzheimer's dementia rather than actually change the course of the disease. It focuses, or it treats the amount of amyloid in the brain, so it does reduce the amount of amyloid buildup in the brain to a small extent, but it doesn't actually stop the buildup happening altogether. And in terms of how efficient it is, it's quoted that there's about a 50% efficacy. So what that means is there's about a 50% chance that it will help you if you take this drug. Having said that, it's a drug that I've seen used over the last 30 years almost, with really quite good effect for lots of people. So I would say anecdotally, I will often see people who will see a significant slowdown in their memory decline over several years through taking this particular drug. In terms of the other drugs that you've mentioned, so Suvanade was a supplement that came out a few years ago. So it was a liquid supplement that you could take that had particular vitamins and minerals within it. The reason there was a lot of excitement around Suvanade because there was an initial trial for people who had mild cognitive impairment, so very mild memory problems, where it seemed to show some initial benefit. However, there was a further trial done over 2 years that failed to show a slowing in decline in those people's memory problems. And after 3 years, there was a small improvement for some people, or a small, reduction in the decline of their memory problems, but it really wasn't significant. So Suvanade is a dietary supplement that looked very promising initially, but unfortunately the subsequent studies really didn't show that it had a great benefit for people who had mild cognitive impairment or early Alzheimer's dementia. The other
Redimind, I think it was called.
thank you, that you mentioned is again a supplement. The main ingredient of that is something called ginkgo biloba, which again is a supplement that can be taken in a variety of ways: tablets, teas. It's available through in a variety of settings and health stores, for instance. Again, like a lot of these supplements, there's some anecdotal evidence for people that they see it seems to have a benefit on memory, but there have never been any trials that have proven that that has a significant effect for people who have memory problems. So I would say anecdotally, sometimes I've heard people who feel that they have benefited from taking things like ginkgo biloba or Suvanade, but there is, I'm afraid, no robust evidence from trials that there's going to be a significant benefit for everybody.
Okay, am I right in thinking that whereas donepezil would need to be prescribed, Redimind and Suvenaid would be bought over the counter?
That's absolutely correct. Yes, yes.
Hmm.
So, I would say that, as I said, I've certainly seen people over the years that have taken these supplements and feel that they've had some benefit. And I think, as I said, certainly with Suvenaid, for instance, there was some very cautious signs of some improvement for some people. So, if it's something people want to try, I think absolutely. Often there's absolutely nothing to lose, but the benefit is probably not going to be significant for everybody. Um, so, worth trying, but not something that we would recommend that people would definitely need to take. But as you said, donepezil is a drug that needs to be prescribed, partly because there can be side effects with it as well. That has a much higher level of potential benefit for people with dementia.
Okie doke. Now, I've got a question from the chat. So somebody who's actually present at the moment. Is there any research on pseudo-dementia?
Yeah, just to clarify, so pseudodementia is a term that's fallen a little bit out of favor, actually. I'm not entirely sure why, but basically it means for people who, it's not uncommon for people to present with memory problems when actually their underlying difficulty is one of depression. Um, and there's a lot of research going on for the use of into the use of antidepressants, particularly in older people, and what the benefit of those may be. So again, we had a kind of new round of antidepressants come into the market in the 90s, around the time that we had donepezil come onto the market, and a lot of those antidepressants were a huge improvement on some of the antidepressants that we had previously, that caused an awful lot of side effects. And we've had another kind of flurry of new antidepressants come on in the market in the last kind of 10 years. Um, so it's in a way, there is a lot of research going on into the potential for new antidepressants coming onto the market, and pseudo dementia really just implies if we get better at treating depression that can present cognitive problems. Are we getting better drugs to treat depression, basically? So yes, there's a lot of research going on into antidepressants, and whether presentations may include things like cognitive problems.
Okay, when I was caring, actually, there was talk of carers' dementia. I wonder if that's linked to pseudo-dementia, because I'm sure it's linked to depression and stress.
Absolutely. As I said, broadly speaking, pseudo dementia means you have some kind of underlying depression that presents like a dementia. So your primary symptoms are complaints of memory problems rather than low mood. And I think, unfortunately, for lots of carers, the stress that they have often through their carer role means they may well develop a
Mhm.
clinical depression, and could well present with memory symptoms rather than the more traditional symptoms that we would expect of low mood.
Yes, I'm sure. Now, there's another question submitted in the chat. Is there a link between type 2 diabetes and dementia?
Yes, and simple terms there is. So we've known for a long time that type 2 diabetes increases your risk of things like stroke and heart disease. And more recently, it's been proven that it increases your risk of dementia, and in fact, all dementias across the board. Again, what isn't always clear from these initial studies is why, and what is the thing that's kind of driving that association. So there was actually a study that came out not too long ago, which looked at a really large ongoing cohort of people, um, and particularly looked at whether when your diabetes started, whether that was associated with your risk of dementia or not. And the results from that study actually showed that the earlier you develop diabetes, type 2 diabetes, the greater your risk for developing dementia. As I said, what was interesting, or what came out of this study, was trying to understand why. Um, uh, and it certainly seems that the fact that diabetes increases your risk of things like strokes and reduces your cardiovascular health generally is not the only reason. Um, it seems that probably one of the things type 2 diabetes does is, because you are at risk of these low blood sugars, periods of low blood sugars, that may actually directly damage the memory areas of the brain. So these are, again, the hippocampi that I referred to before. And in fact, there's also some evidence now that insulin itself may play a role in the formation of amyloid plaques. So again, this protein that builds up in Alzheimer's dementia and causes problems with the nerve cells working effectively for memory. And so although we can see very clearly there's a link between type 2 diabetes and risks of Alzheimer's dementia and dementia across the board, we're really only now starting to understand why, and the fact that it isn't just because, as I said, it increases your risk of stroke, but it may be related to how commonly your blood sugar dips, and that having a direct effect on memory areas of the brain, or levels of insulin actually causing buildup of amyloid plaques as well.
Goodness. Okay, now here's a question directly about care. Is there any research taking place into different approaches of care for people with dementia?
Yeah, there is. I think it's tends to be a fairly under-researched area, to be honest, though. So there has been some research done previously as to whether people who are supported in particular care environments have better outcomes if they have memory disorders and dementia. And there's certainly some evidence that if you are supported in a specialist care unit with staff that are trained in supporting people with dementia, if there are appropriate physical environment adaptations within the environment, there's extra staffing, specialized training, you seem to have a better outcome. So there was a study back in 2018 which showed that if you were supported in a care unit with specialist staff and training, you were less likely to need to go to hospital, you were less likely to need certain symptomatic treatments, you had less problems with things like agitation and restlessness. And I mean, I think all of that is quite logical and seems to make a lot of common sense. But I guess, again, what we're not quite understanding is which aspects of those specialist care centres are most important. You know, is it about staff training? Is it about the physical environment for people within those care units, or, you know, something else that we're missing? So I think it's a somewhat neglected area, if I'm honest, but there is some research certainly going on as to whether particular types of support for people in care settings are important in terms of their outcome.
I think every carer on this webinar will probably laugh hollowly at the idea it's a neglected part of research. But moving on, there's a question, few people have asked about this actually. Can sleeping habits impact on the likelihood of developing dementia?
Yeah, again, a really interesting area, partly because we know that sleep patterns also change with dementia. So people with Alzheimer's disease often wake up through the night, find it hard to get back to sleep, and there seems to be some shift in people's kind of sleep-wake cycle, their circadian rhythm with dementia. So interestingly, there was a study that just got published back in 2021. This is an American study, actually, but also there was further research done at University College London, which looked at people's sleep in their 50s and 60s. What they found was that if you were getting 6 hours of sleep or less, that seemed to be associated with a greater risk of developing dementia later in life. So the cutoff line seemed to be around 7 hours or more. And if you were getting less sleep than that, that certainly seemed to predict an increased likelihood of getting dementia later in life. And that was in that study, they adjusted for other factors that could influence your risk. So things like diabetes, smoking, physical activity, some of the things we've already touched on. So this type of research, which again is really still in its infancy, certainly suggests that there's something about short sleep duration that may affect your subsequent risk of developing dementia later in life.
A supplementary one to that. What about people who work shifts, work in night shifts and so on, nurses and so on?
Yeah, I think again, there's limited research out there. There is some sense that the reason why that short sleep pattern is detrimental is because you don't have the length of sleep to go through the full sleep cycles. So your normal sleep cycle that we all go through in each night is disturbed. So there's certainly early evidence that if you have a very disturbed sleep cycle because you're having to get up at night, or maybe you're doing shift work where your sleep pattern changes all the time, that could certainly have a negative impact as well. But it's still, again, very much in its infancy in terms of research.
Okay. The next question is about hormone replacement therapy and whether that has any effect on the likelihood of developing dementia.
Yeah, another area of real interest at the moment, and I have to say that most of the research done to date has not had given us a clear answer. So there was actually a review of this published a couple of years ago that looked at studies that encompassed about 16,000 people who already had a diagnosis of dementia, women with a diagnosis of dementia, and also about 60,000 people who didn't, who had been taking hormonal replacement therapy for more than 3 years. And overall, there was no association found between whether people had HRT and subsequently developed dementia or not. I think research prior to that was, again, very conflicted. There were some trials that suggested there could be a benefit for HRT, others that showed no particular results. But one thing that has been published very recently, actually just January this year, was a piece of research done in the University of East Anglia and the University of Edinburgh that looked at the data from something called the EPAD study. So this was a really large cohort study called the European Prevention of Alzheimer's Disease Cohort Study. And this involved over 1,000 women. What they did was look at whether women, and this were people who did not currently have a diagnosis of dementia, whether the likelihood of them developing dementia as time went on was connected with whether they took HRT or not. But what they allowed for that other studies often hadn't was whether the women had this ApoE4 gene that I talked about earlier on. What they found was that there seemed to be a benefit of taking HRT in terms of your risk of developing dementia if you had the ApoE4 gene. So it's very interesting in the sense that it's a really large sample. They particularly looked at the impact of whether this ApoE4 gene altered your response to HRT, and certainly that particular study suggests maybe it does. But again, I think what we need to be doing at this point is more research, and particularly research where we follow women up who don't currently have dementia but are taking HRT, follow them up over a period of time and see whether the likelihood of them developing dementia changes.
Okay. Another question from the chat. Are episodes of momentary blackouts an indication of the onset of dementia? There's nothing more said about the momentary blackouts, but I wonder if this includes things like, I understand there's something called global amnesia or something, transient global amnesia.
Yeah, transient global amnesia, I kind of interpret as being more short-term absence of memory rather than blackouts. I would say that they're not particularly a sign. There are certainly some cases, and I've certainly seen some patients over the years that seem to have sometimes almost atypical or unusual seizures. So I do remember one particular patient who used to get drop attacks that seemed to be associated with Alzheimer's disease that developed over time for this particular patient. But they're not a common presentation. I think, honestly, if somebody said to me that they were experiencing blackouts on a regular basis, what I would be more likely to think about is epilepsy or possibly something else, some other kind of brain injury, or that could be causing those blackouts. So possibly a stroke, possibly tumors, but predominantly I would be thinking about epilepsy. They're not particularly connected with dementia per se. So I would probably think that if someone is experiencing those, they should be going to see a doctor to have other particular disorders excluded.
Okay. And somebody else asks, are you in need of brain donations to help with dementia research? And if so, how does one go about organising this?
Yeah, we absolutely are. At the moment, one of the problems in researching all forms of dementia is that we don't have a gold standard test to diagnose any of the forms of dementia. So, for instance, if you are going to a doctor who's going to see if they think you have diabetes, they can basically do a blood test and say, yes, you have diabetes. All types of dementia, because they're much more complicated diseases, one test does just not tell us. So you can have a brain scan, you can have a lumbar puncture, so we look at the cerebral spinal fluid and see whether the proteins like amyloid have built up in that, but none of them give you 100% answer. The only thing that tells us 100% whether you have Alzheimer's disease or a Lewy body disease or any other of these causes of dementia is to look at your brain after death. And what brain donation does is it allows us to look back at people's records, clinical records, or if they've been in a research study, correlate some of the performances on things like memory tasks during life with their brain donation if they donate their brain. And the more that we can compare the information we get from brain donation with how people are in life, the more likely we are to get to a gold standard test at some point. I suspect it will be a collection of tests rather than one, but that nevertheless, the more we are able to examine people's brains after death, the more we can understand what we need to look for in life. There is a big study going on at the moment called the Brains for Dementia Research Study, which is funded from the Alzheimer's Society and Alzheimer's Research UK. That's been running since 2007. At the moment, that study is now closed to recruitment, however, because they had enough people through the study. But what it did was establish a network of brain tissue banks to help facilitate brain donation. So what I would suggest if people are interested in donating their brain is to go on the Brain Bank Network for the UK. You can look that up on brainbanknetwork.ac.uk. And on that website, if you have access to the internet, you can see a list of your local brain bank. And I would suggest if people are interested, do get in touch with your local brain bank and they will help support you with organising how you can donate your brain in later life.
Yes, thank you. That's a very interesting one, isn't it? A very specific dietary question next. Is there any research into whether sugar consumption contributes to dementia?
Yeah, there is. I think part of the issue, again, with all of these dietary questions, and I've touched on this a little bit before, is because it's so difficult to isolate what that particular component of diet is doing to your risk of dementia, partly because obviously we're all eating and drinking different things all the time, but also because something like sugar, we know increases your chance of having things like vascular disease generally. And as I've mentioned earlier, vascular disease is a risk for all forms or a risk factor for developing all forms of dementia. But there was a study that came out a couple of years ago now from a large cohort, so a large group of people being followed up long term, called the Framingham Heart Study. And this was based in the US. And what they looked at was people's sugar consumption in drinks over several years. And then, because this was a cohort of people being followed up long term, they then looked at whether they developed dementia or stroke 15 or 20 years after that. So this was a really large study. that involved several thousand people. And what they found was a higher sugar consumption in these drinks was associated with an increased risk of dementia and stroke. As I said, it's a little bit trickier to work out what that means, what's driving that. So is there a direct link between sugar and dementia or Alzheimer's disease, or is it because sugar increases your risk of cardiovascular disease generally, and that increases your risk of dementia?
Okay, well, we're coming very close to the end of our time now, so only one more question, I think, but it's probably quite an important one. Are there any tests for the APOE4 gene?
Yeah, absolutely. The APOE4 gene, as I said, is the one gene that we know is associated with increased risk of late onset Alzheimer's dementia, which is by far the most prevalent type of dementia in the population. You can have it tested via saliva, so it's a very simple test. We don't routinely do it for people, and the reason that we don't do it is, again, I kind of mentioned a little bit earlier on, we know that if you have this gene, whether you have one or two copies, means you have an increased risk of developing Alzheimer's dementia, but it's not 100%. So it doesn't mean that if you have an APOE4 gene, you will get Alzheimer's dementia. And if you don't, that you won't. So to date, we have not provided this routinely. So if you go to your GP and said, I would like to have a test for APOE4, or if you go to a memory clinic, we don't routinely test for this. That's starting to shift. And the reason is because as we are developing these new drugs that may be even more effective at preventing dementia or changing the course of the disease, it becomes even more important to identify people at risk before they have memory problems. So as I said, so routinely this test is not available. If you go to your GP, they would not be able to provide it. I will say, however, you can APOE4 testing is one of those things that is covered by a lot of commercially available genotyping kits. So things like 23andMe, that is available commercially, does include a test for APOE4. I would just be cautious, as I mentioned, that if you go ahead and buy one of these kits, and it's a very simple process, as I said, because we can do this just with saliva, even if you come back as positive for APOE4 for one of the genes or two of the genes, there is a level of interpretation needed in order to understand what that may mean for your overall risk of getting Alzheimer's dementia. Because again, as I hope one of the things that's come out of this webinar is that things like Alzheimer's disease are an incredibly complex disease, and lots of risk factors really have to come together for one person to develop Alzheimer's versus not to have Alzheimer's. So APOE4 is just one risk. So you can have APOE4 testing done. As I said, there are commercially available kits to do it, but I would just be very cautious that if you go ahead and do that, it may be worth having a discussion with your GP to understand the context of what the results mean.
Well, thank you, Vanessa. Thanks for all your hard work. And thank you to everyone for providing questions. I think a very good and very interesting cross-section of questions. And I hope you found it an insightful and informative session. Thank you to our hosts, the National Institute for Health and Care Research. And remember, if you want to learn more about research and how you can take part in studies, even if you're healthy, search for the Be Part of Research website. So just Google Be Part of Research. And you'll be sent a recording of tonight's event as well as an evaluation form. And we would be very grateful if you take a moment to complete it. We want to run more of these events, so we want to know what we're getting right and also what can be improved. So it remains to me to thank you all again. Thank you, Vanessa, and thank you to our hosts. And I hope you all have a pleasant evening. Good night.